Hey everybody, it's the Glaucomfleckens. We are bringing our live show, Wife and Death, to Boston. We're coming to the Huntington Theater September 14th, just right around the corner. We cannot wait, especially because we're coming to Boston before it starts snowing.
Theoretically, yes.
Hopefully, it's going to be great. It's going to be great weather. Come on out. We can't wait to see you. Get tickets now, glaucomflecken.com/live. We'll see you there. Knock, knock. Hi. Welcome, everybody, to Knock, Knock, I, with me, your host, Dr. Glaucomflecken. Of course, your one-stop shop right here for all things eyeball related. So the eyeball stuff we got going on today is we're going to talk about medical malpractice, specifically as it relates to ophthalmologists. If you're not an ophthalmologist, is that going to interest you? Maybe not, but I thought it was interesting. And I'm going to talk about basically the top 5 risks for malpractice for people like me. And do I agree with them? Do I think that they should be open to malpractice claims? What do I do to try to mitigate that risk? Even though I don't really think about mitigating malpractice risk very often, but are there things that I'm subconsciously doing, right, to keep myself from getting sued? Because people love to sue you in this country. So we'll get to that after the break. First, I've been waiting all week to talk about the new CMS, the proposed CMS rules. What do you call them? It's just a proposal from Dr. Oz, the one and only Dr. Oz, Lord Commander of CMS. And he finalized for 2027, he finalized the Medicare and Medicaid reforms, focusing on value-based care pathways. I'm just summarizing here, then we're going to jump into some of them. So Medicare and Medicaid reforms, really pushing value-based care, all right, which you could think of like 2 different ways of paying healthcare workers for the work they do. One is like fee for service, which is traditional, what has been for what doctors started with. You do a thing, you get paid for doing the thing. That's fee for service. We still have a little bit of that, but the push has been really since the 70s, since the HMOs, since the health maintenance organization revolution in the 1970s with Nixon. Ever since then, we've been had this gradual push toward managed care and also value-based care, with the idea being we got to rein in all of these crooked and greedy doctors who are doing all these terrible things. Don't worry about the insurance company. No, they're fine. The insurance companies, they're trying to keep you in check. No, don't look at us. Nothing to see here, folks. It's the doctors. All right. It's the doctors. They're billing you for things they don't even do, or they're overbilling you and they're sending you to collections. They're horrible, greedy, awful, evil doctors. So we need to do what we can. We need to design a healthcare system to just try to rein in these the Satan of healthcare, which is the physician, the profession of physicians. Anyway, that's how I feel about managed care and this push toward value-based care. The idea is that with value-based care, you are paid as a physician based on how healthy your patients are. That's the idea, which on its face sounds great, but this is exactly what insurance companies want. It's what health systems want. I think we have enough evidence to show that does nothing to rein in costs. Things are just getting more and more expensive, and that should tell you it's really not the doctors, right? Let's all say it together. Physician compensation is 10% of healthcare expenditure in the U.S. Physician compensation is 10% of healthcare expenditure in the U.S. We're talking about trillions of dollars healthcare expenditure. Physician compensation is only 10%. So you want to rein in costs? All right, look elsewhere. Get rid of middlemen. Get rid of PBMs. Break up vertical integration. allow physicians to own hospitals again, bring in a little bit of competition with these big health systems that are just getting larger and larger, in part because we are pushing everything toward this managed care, value-based care. And Dr. Oz's 2027 recommendations for CMS is just pushing us further in that direction. And you'll see here in a second why. Also did some good things. I like some things that are on this list. Talking about digital prior authorizations. Let's get into some of these. So let's start with the patient, the bad stuff. Bad news first. All right, physician payment and what this does to reimbursement. Obviously, I'm biased because here's the background. And for those of you who are not physicians, who are not maybe not even in healthcare listening to this, this is why is it that physicians are always talking about reimbursement? Because, hey, you guys are paid really well. Yeah, we are paid well. And we would like to continue being paid well because we did a decade of training. We are very highly trained. We do surgeries. We take care of chronic illnesses. We take care of emergencies. We save patients' lives. Not me. I'm an ophthalmologist. I save their eyeballs. I do that sometimes. Not often. Fortunately, I don't have to. But anyway, yeah, we are always talking about physician reimbursement. And the reason is because it is constantly cut every single year. We get, despite costs going up, despite hospital systems, they get an increase in reimbursement every year from Medicare and insurance companies. Like their insurance, their reimbursement goes up. Physicians across the board for CMS, it goes down every single year, sometimes by like double-digit percentage points for certain services. They just pick different services that different types of physicians do. The only people that have had an increase are like primary care, family medicine, which is great for them. Like we should all be applauding that. But it really, like, it should be across the board. Why are we cutting? Why are we getting a pay cut every year? And it doesn't make sense. So we're tired of it. And as again, year after year, imagine like whatever it is you do for work, instead of getting a little pay bump, you get a pay cut. How would that make you feel? Right? It make you feel like no one cares about the work you do or values the work you do. That's kind of how we feel as physicians when we see CMS come out with new guidelines or the most recent round of Medicare cuts. And so the big changes here. So speaking of pushing toward like value-based care, they're really wanting doctors to form these accountable care organizations called ACOs. So ACOs really got started in like 2012 with the Affordable Care Act. Again, like it's been a gradual, sometimes not so gradual push toward this value-based care. Basically, an ACO is when a bunch of, I think it's usually primary care docs, come together. I'm not an expert in this, so I'll apologize if I get some of this wrong, but they come together. Sometimes hospitals are involved typically, to form this network. That's basically all the payment is based on how healthy the patients are. So, as you can still be like own your own practice, but you can be, as your practice can be part of an ACO. And so you pay some money to the ACO. And the idea is that, if your patients are healthy at the end of the year, or you did a good job keeping your patients healthy, then you get some, like a bonus of money. And that's built into how CMS pays practices, pays doctors. All right. So there's reimbursement bumps for healthy patients. But the obvious downsides that you can see is like, what if you just have a patient population that's incredibly unhealthy? Right? Like how do you factor in the wide demographic differences across this country? The wide socioeconomic differences across this country. And maybe they do that. Maybe I'm just not aware of it. But that's my like initial concern is like, what's to stop someone from just like only taking on healthy patients and saying, oh, we're not going to see all these sick diabetic patients. No. So I don't know. I don't know. I need to learn more about ACOs, but in general, the push toward value-based care, I don't think is the right one. I understand people's concerns about fee-for-service, how there's always the possibility for bad actors, for physicians to game the system. But I think it's going to be a very, very small minority because they're watching for this stuff, right? Like every year there's, doctors that get dinged on Medicare fraud. By the way, there's also a lot of health systems, for-profit corporations, private equity firms that are also getting sued for Medicare fraud. So, do you go toward fee for service and help out, independent physicians? Do you go toward value-based care, which helps out the health systems and insurance companies? I know what I would choose, but again, I'm biased. So anyway, there's an increase in so part of these CMS guidelines, they're increasing the reimbursement for basically they're incentivizing being part of an ACO, one of these accountable care organizations. But the biggest thing that's been making the making waves on social media is the multiple procedure cuts. All right, so I'm going to explain this to you. When a patient comes in to see you in clinic, let's say you're a dermatologist, or even me, I'll take me for an example. Ophthalmology, a patient comes in for a diabetic exam. I will usually bill what's called an E&M code. Exam, what does E&M stand for? Honestly, I don't even know. I just call it E&M codes. Examination and management, medicine? I don't know. E&M. That's just how you see the patient, you bill a Medicare code, an E&M code, and then you get reimbursed by Medicare. Well, what happens if the patient comes in for their diabetic eye exam, but they also have a sty? It's been there for about a month. It's really unsightly. Patient wants it gone. So before I could, like right now, currently, and what it's been like for years and years, I can bill my E&M code for my diabetic exam because I do the exam. And then if I also do the procedure to remove the chalazion, the sty, make a little incision, drain that blocked oil gland. Sometimes it takes about 15, 20 minutes or so. When I do that, I can also bill that as well. And then I can check off this thing called a 25 modifier. I check that off. That allows me to be paid the full amount for the E&M code, the diabetic exam, and also I get paid the full amount for the chalazion procedure where I remove the chalazion. And everybody's happy, right? I get paid for the work I do for doing both things. Well, now the proposal is that if an E&M visit is billed on the same day as a procedure like a chalazion, then Medicare will only pay the most expensive service. Let's say it's the chalazion. I get paid a little bit more for that. Then I'll get reimbursed 100% for the chalazion, but only 50% for the other thing, the E&M code. Regardless of whether or not you check a modifier, regardless if they are two completely separate problems that the patient came in looking for. Like they didn't come in for a chalazion repair and I did the exam, I bill that and the chalazion. Like, yeah, I would understand, only getting, not getting paid as much for one of those things, but they're two completely separate issues. What if, and this is massive. This is like, it's like the CMS is declaring war on independent physicians, on private practices. Because now we are getting not only do we get the normal reimbursement cuts that Medicare always factors in every year, but now they're cutting our ability to get reimbursed for doing multiple procedures on the same day, even though we are doing the work. I'm not doing 50% less work for that second thing. I'm doing 100% of the work for both things. I should get paid 100% for both things. But now, no, you're only getting paid 50%. So this is a huge, huge boon for insurance companies, Medicare Advantage. Because now insurance companies take their recommendations what they propose for their reimbursement based on Medicare. So if Medicare does something, insurance will follow. So now we're stuck in a situation where if this goes through as written, you're going to have a dramatic loss of revenue for private practices. And this is exactly what CMS wants. Exactly what Dr. Oz, the administration, everything, this is what they want because they're pushing people toward health systems. They want all of us to be part of ACOs, managed care. They don't care about doctor independence. And it's not just financial independence. It's independent medical decision making. That's what I'm fighting for here. The reason I want to stay independent as a private practice physician is because I like making my own decisions without having administrators influence that. Without having a parent private equity company saying, oh, you know what, you really need to see 8.5 more patients per day to meet threshold for whatever the fuck we're doing. No, I don't want that. I want to have agency over my own schedule. I know how many patients I can safely see and still give those patients the time that they need. I know that. I'm the doctor. The suit doesn't know that. But this is what CMS is pushing. They're just needling. It's like death by 1,000 cuts for private practice docs. Just a little cut here, a little cut there. Oh, you know what? 50%, you're only going to get 50% of what you used to get for that procedure. And it's not just ophthalmology, it's across the board. Think about a patient who comes in for, let's say, even into the emergency department. What if they need a procedure in the emergency department? So the emergency physician can only get 50% for like having to do a lateral canthotomy or a lumbar puncture. Like these are time consuming, sometimes costly procedures. And so you're just putting all the burden on physicians, on people who see patients and bill for services. We're getting dinged for the work we do, yet you have dozens of middlemen. It's just like let's just not even pay attention to all the waste that's happening on the insurance side, with PBMs, with pharmaceuticals, with just all the private equity stuff. It's so frustrating that this is what's happening. Anyway, so I don't like it. I'm not a fan of the cut to the procedure reimbursement. And this is a big one. It's a big one. That's why everybody's talking about it. It's very frustrating. So one thing that CMS, I got to give props to Oz for this, is mandating real-time electronic prior authorizations across Medicare Advantage, Medicaid, and ACA marketplace plans. So great. If we're not going to just get rid of prior authorizations, then at least make them electronic. Sure. Okay. Like you're doing the bare minimum here. So props to you, I guess. That's fine. And also just trying to minimize approval delays. I don't know. Like we'll see if that actually happens. So I would encourage more work to be done, limiting, decreasing prior authorizations. Like we need to really rein that in and get it, because it's just another thing I'm not a big fan of is implementing another CMS recommendation is implementing Medicaid work requirements. And I understand why they're doing this. I think it's 80 hours per month starting January 1st, 2027. So basically, you have to work 80 hours per month, or maybe you're searching for work for 80 hours a month. I'm not sure how they decide that, similar to like unemployment benefits, right? But there's the guidelines for like to qualify for Medicaid, you have to like work 80 hours per month. Every month, is this an average? Is this like, what if you just got a job, but you're out of work for a couple months? Is that held against you? I'm not sure. But one thing from the physician standpoint is that I can see like this just adding more to the administrative burden of medical practices, of private practices, of physicians who have to prove in our billing and our documentation that this patient is working 80 hours per month? Or what if they're not able to work? Like, do I know what it takes to be a bricklayer or a theater performer or whatever it is you do? And do I have to document that? Do I have to be able to say, well, this patient should be able to work 80 hours? So I just don't understand the implementation of this 80-hour work requirement, and how that's actually going to work on the physician side, on the billing side. Is that going to be, I imagine it's going to be, because they love to put more work on us. I imagine that's going to be put on us to document how many hours the patient's working, or maybe the patient has to submit paperwork, qualify. I don't know how it's going to work. So anyway, I'm skeptical of anything CMS, anything that the government tries to do with Medicaid, at least this administration, because usually it's been, I think, a bad thing, especially with the One Big Beautiful Bill and the massive cuts that are hurting rural hospitals. All right, that's it. That's all I'll bore you with all the, so not great, not good stuff. I mean, was it ever going to be good? No, I don't think so. But those are my thoughts. I would love to hear your thoughts. Leave a comment on my YouTube channel at glaucomfleckens, or you can email us, knockknockhi@human-content.com. Reach out to me on social media. If what your thoughts are on all this, if I got something wrong or I need to be thinking about something in a different way, please, I'm open to suggestions and comments. All right, let's take a break. We'll come back with some ophthalmology. We are very excited to tell you about a healthcare news podcast that just came out. It's called Medlines.
See what we did there? Medlines, headlines.
That's good. That's good, right? It's a weekly wrap-up of everything in our field, from breakthrough discoveries to research, politics, pop culture.
Yeah, I think the best way to think of it is kind of like NPR's Up First podcast, but for all things healthcare.
And we're excited to be a part of the team behind it, along with our partners at Human Content and our inaugural sponsor, the New England Journal of Medicine.
Yeah, we wanted there to be a podcast out there for busy healthcare professionals to stay informed on the go without taking a big chunk out of your day.
It's the episode's 15 minutes.
Yeah, or less.
That's like the length of a cataract surgery.
Exactly.
Episodes of Medlines are out now wherever you get your podcasts, with new episodes out every Friday. Check it out. Hey, Kristen, remember how you love eyelid mites now?
Mm-hmm. Sure.
Yeah. Well, there's a lot of confusion out there. I want to clear something up.
Okay.
All right. People think they can get eyelid mites from dogs and cats.
Can they?
No. These particular Demodex mites are specific to humans.
Okay.
So spread from dogs and cats is not expected. That's a myth.
Can't get them from cuddling our poodle.
No. Demodex mites that cause blepharitis live on humans. Most adults already have them. They just usually don't cause problems. It's when they overgrow that they can lead to itchy, red, irritated eyelids. Those little collarettes.
Mm-hmm, the crusties at the base of the eyelashes.
Right.
And the good news is there's a prescription eye drop available for Demodex blepharitis.
That is great news. To learn more about eyelid health and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. So I just had a colleague that I spoke to recently who just got out of a litigation, medical malpractice claim, lawsuit, did not go to trial, but did have to settle. And this is one of the most harrowing experiences, I think, professionally, that a physician can be forced to go through, because we are so perfectionist that whenever we do something, we're perfectionists, but we're not perfect. And that's a bad combination. Whenever you have the possibility of messing up, but you hate to mess up. And it feels even worse when a patient feels so hurt by what you've done, either physically or emotionally, that they decide you need to pay them damages for that. And don't get me wrong, medical malpractice exists for a reason. I think there is abuse in it. I think there's obviously some claims that should never be filed, but sometimes like you got like a doctor death situation. That's an extreme example, but there it's necessary because sometimes doctors do things that are outside the standard of care that harm people. And so if that happened to me, sure, I would feel if something, I don't know what would have to happen, but if it was, clearly outside the standard of care that harmed me or a family member, I might consider a lawsuit, sure. But that, I would say that situation doesn't explain the sheer volume of medical malpractice lawsuits that we experience in this country. And so just having this conversation with a friend of mine and made me think of okay, well, what I haven't checked in on this recently. What are like the most common things that ophthalmologists get sued over? All right, so I've got five things. One is something related to cataract surgery. So usually it's um, surgical complications with cataracts. So you have posterior capsule tears. So when we remove the cataract, sometimes we can nick the posterior capsule, which is the back part of the cataract, and cause the cataract itself during surgery to fall into the back part of the eye. And that can result in prolonged recovery and sometimes permanent vision loss. Um, Also, just retained lens fragments. Unfulfilled patient expectations is one. I wanted this, you gave me that. That's not what I wanted. And that's a tricky one. That's where documentation really comes into play. One of the most common ones is whenever you're getting cataract surgery, the patient, you can decide, do you want to see better without glasses up close for reading or distance far away? Now, there are some lenses that can give you both, but most patients go for one or the other. And I have that conversation at least 3 different times with the patient. Even though I know what they've chosen, I confirm with them and I document it several times because I have been in situations where I know for a fact the patient wanted distance vision, but then they come back, they're like, my near vision is terrible. I didn't know this is going to happen to me. And you have to do your best to kind of mitigate those communication errors. Sometimes you just can't. To the best of my ability, I have tried to make sure the patient understood you will have good distance vision. Your near vision will be terrible. You will have to wear glasses. Sometimes it just doesn't compute until the patient actually experiences it. And those are always tough situations, right? Is that worth, like, does that qualify for a lawsuit? No. But I know people who have been sued for that exact reason. And that is not appropriate. Now, fortunately, something like that would never, if as long as you document everything correctly, that wouldn't result in a payout or any kind of conviction or anything. But anyway, so cataract surgery, that's one big category. Retinal detachment is a huge one. All right. So delayed diagnosis, uh, not performing a dilated exam when you need to. A patient comes in with flashes and floaters, you got to do a dilated exam. You got to look for it. And if you miss it, like you might be on the hook there, or just missing any kind of retinal detachment or retinal tear, because a retinal tear can easily transform into a retinal detachment, and that can be a blinding condition, and you might be in trouble if you miss something like that. So I am very diligent. Any patient who has a symptoms that sound like a retinal detachment, that's what I'm trying to say. There you go. Glaucoma management is in the top 5 as well. Insufficient monitoring of eye pressure. That's what we're always checking on when you come in with glaucoma. We always check your eye pressure. You don't check a pressure or you don't document it. Ooh, you're in trouble. Someone has glaucoma. Glaucoma. That's like the thing you do. That is the modifiable risk factor for glaucoma is eye pressure. You know how to treat glaucoma? It's very simple. You lower the eye pressure. That's it. That's your singular goal in glaucoma management is lowering eye pressure. There are 1,000 ways to do it, so it's not an easy specialty by any means, but it's easy in that you have one goal in life: get that pressure lower. I kind of jealous of them for that reason. It's like that's all you are focused on doing, lowering the eye pressure and using one of dozens of different things to do that one thing. Um, Post-op infections. That's another one. And so a lot of these are related to procedures because procedures do carry that risk, right? They carry the risk of a complication, which is Very frustrating. And two of the common drivers of these is three common drivers that will push someone to sue their doctor. And this is coming from OMIC, which is the big malpractice insurance carrier for ophthalmologists. One is documentation deficiencies. That's easy to avoid. Just document diligently. That was drilled into my head when I was coming up in med school and residency. You always document the hell out of everything, because we are a litigious society, right? So you got to protect yourself, and you just got to be accurate in your notes. Communication gaps, right? Not explaining things well with patients, not spending time, not developing trust and rapport with a patient. Like, if you do all of that, that goes such a long way toward building the relationship that can survive something like a surgical complication. The last one, technical performance. Roughly 60% of liability claims regard surgical execution errors. Now, some of them are probably warranted, but I bet some of the lawsuits are probably warranted, but I bet a lot aren't. And it's just so deflating as a surgeon, because the only way to avoid complications in surgery is to not operate. And I think a lot of people don't realize that. They come in for something like cataract surgery and they just assume everything's going to go perfectly well. That's why informed consent's really helpful. Talk about, sometimes I have somewhat of a negative, I don't lie, but I'm truthful. Sometimes, even to the point of painting a pessimistic picture about how cataract surgery might go for certain patients, because the risk is higher for certain patients, depending on what else is going on with their eyes. But I'm brutally honest. You have to be, because it sets the patient's expectation. And if you're truthful, you have that honest conversation, you're going to build a better relationship with that patient. And if something goes bad, you're there for them. You're communicating with them. You're telling it's so, even though if something goes bad in the operating room, it may not be your fault. You may still be liable for it, but you can mitigate that risk by just being good to the patient and communicating effectively. But the shitty part of it is that even if you do everything exactly right, except your hand slips, or the patient moves during cataract surgery because they're awake, and your chopper goes through the bag and you have a complication, even though you communicate well, you see that patient in follow-up, sometimes you might still be sued. And that is what breaks doctors. When you did everything you possibly could to the best of your ability, and you still have someone coming after you for $1 million. I don't know what to do about that, right? You just kind of hope it doesn't happen to you. So, there you go. Ophthalmology, malpractice. I think ophthalmology is maybe middle of the road in terms of malpractice risk. There are certain specialties that are certainly much higher, like OBGYN, emergency medicine. I think ophthalmology is typically a little bit more of a controlled environment. You know, um, and cataract surgery at this point is fairly routine, but yeah, I mean, it still happens in every specialty. But the surgical fields are always going to be a little bit on the higher end. Anything where there's like heavy procedural risk, you're going to have more malpractice claims. All right, that's it for Knock Knock Eye. Thank you all for listening. I'm your host, Dr. Glaucom Flecken. Thanks to my executive producers, Aaron Corney, Rob Goldman, and Shanti Burke. Our editor and engineer is Jason Portizo. Our music is by Omer Benzvi. Knock Knock Eye is a human content production. I'll see you next week.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.